Thank you very much to Towcester Vets for inviting me, and thank you for everyone for turning out on a very cold wintry evening. As Alice said, we're going to talk about sarcoids and some other skin tumours of horses as well. We're going to look at some of the newer treatments, which I'm glad to say have arrived, which are helping us to deal with these very difficult conditions. So just a little bit about me. This is really sort of my day job. On the right-hand side here, dealing with skin tumours in horses. That's what I've specialised in. I do some wildlife work in South Africa as well, so occasionally mess around with big cats too. But predominantly, as I say, it's the stuff on the right-hand side that I spend my time doing. So just a little overview. Oh yes, there are some relatively unpleasant photographs. Anybody with a nervous disposition at certain may want to look away, but I think the flyers which were produced, which were great actually, I think they were pretty graphic, so you kind of hopefully know what you're in for. So what are we going to talk about? Well, we're going to talk a little bit about sarcoids predominantly, but we'll also look at some of the other skin tumours as well that we commonly see. We'll talk about the clinical signs that we see, kind of obvious if you've got something that size. And then we're going to talk about the implications for the patient. So how does it affect the patient? What are the outcomes in terms of the patient's health? And then we're going to spend quite a lot of time looking at treatment options, the various treatment options that are available. We're going to spend some time looking at carbon dioxide laser surgery. That's something that in particular I've specialised in and I've been doing for the last 8 years, and hopefully as you'll see we can get some really nice results using laser surgery. We're going to talk about a technique called photodynamic therapy, which is a treatment which is very commonly used in human oncology for treating skin tumours in humans, but it's relatively rarely used in the veterinary world, which is a shame because it works extremely well. I started using it probably about 3 years ago, and again, hopefully you'll see from the photographs and from some of the data that I'll present, we've had some really, really good successes with it. And then we'll talk about, again, another technique, or in this case a drug, Mitomycin, which is commonly used in human oncology and is relatively new in the veterinary sphere. And again, I've been using that for just over a year, and again we've had some very nice results. So suddenly we've got some new treatments available, which we're beginning to get good expertise with, and we're beginning to get some very nice results with. Okay, so first of all, let's just talk about sarcoids in general. So they were first described in 1936 by a South African vet called Jackson, but of course they've been around for a lot longer than just 80 years, probably for thousands of years, and wherever we find horses around the world, we find sarcoids. We categorise them into 6 different types of sarcoid, depending on their appearance, and we'll go through the 6 different types. There's a type of tumour called fibroblastic, verrucous tumours, then we have occult tumours, nodular tumours, mixed tumours, and finally a very rare form, the malevolent or malignant sarcoid. And we'll have a look at some photographs of each type. So yes, here's another model photograph. So this is the fibroblastic form. So this is a very aggressive form. This is looking between a gelding's back legs. This was one of the first cases that I saw actually in first opinion practice, bit of a poison chalice. So you can see very unpleasant. Eventually, once the tumours reach a certain size or a particular size, the skin is no longer able to accommodate them any longer. Obviously the skin is relatively stretchy. It will depend where the skin is on the body as to how much stretch and give there is, but eventually once the tumours get to be a large enough size, they'll just start to break through the skin and ulcerate in this way, and then start to bleed, and you'll have ooze, and then we've got all kinds of secondary problems. Obviously this is painful for the horse, we'll get secondary infections, and so forth. So that's the first type, the fibroblastic type. This is generally where sarcoids sort of head to. So this is the worst end of the spectrum, but some of the less aggressive forms over time will tend to turn into this kind of presentation. This is the verrucous form of the sarcoid, and verrucous just means scaly, and it's a good description really. This is a particularly large one. It's on the neck of a polo pony. This was a case in South Africa actually. And you can see it looks a little bit like a human wart or a verruca, and that's where a verruca gets its name from, because of this verrucous or scaly appearance. This is another one. This is over the jugular groove, just here, so where we would inject horses commonly, over the jugular groove of a horse. And it's a site that I see quite a lot of sarcoids. And it begs the question, this is slap bang over the site where we would inject. And one wonders whether either in the process when the injection is happening, or alternatively, perhaps when the vets might have handled a sarcoid earlier in the day, and then they go and inject the horse later in the day, whether perhaps we're in some way transmitting the tumour across to new patients. And certainly there is very strong evidence. I spent my master's time at the Royal Veterinary College looking at whether flies are involved in the transmission of sarcoids, and we got very strong evidence to suggest that was the case. And we certainly believe that there is a virus, it's a cattle virus, that's involved in the spread of these tumours from horse to horse, and indeed potentially from cattle to horses. This is a common form as well. This is the nodular sarcoid for very obvious reasons, and this one's sitting in a prime predilection site, one of the most common sites that we find sarcoids in, sitting on the inner thigh of a gelding in this case. So again, a very common presentation, and you can see how this could easily progress on to that rather more aggressive fibroblastic form as it gets larger and starts to become too large for the skin to contain. This is a very subtle form. This is often one of the first, or the first sign that you may have that sarcoids are beginning to develop. This form we call the occult form of sarcoid. Occult obviously just meaning hidden. What else do you think? This is a mare's brisket. Any ideas? What else? If you'd seen that on your horse, what would you think it could be other than sarcoid? Yeah, ringworm. It looks a lot like ringworm, doesn't it? Or perhaps something like rain scald or rain rash, perhaps in the winter as well. So very easily confused with lots of other things, and very easily, therefore, for owners just to think, oh well, you know, that'll regress on its own accord. So if you see things like this at an early stage, at this stage, very often they're treatable with quite simple topical treatments. But as I say, very often these will progress on to the more aggressive forms. This is mixed sarcoid. I mean, there's more sarcoid here, unfortunately, than there is horse, really. Mixed sarcoid just means that we've got more than two types of sarcoid present on one animal. So here, for instance, we've got fibroblastic sarcoids, we've got very extensive areas of verrucous sarcoid as well. We've got some nodular sarcoids here as well. Obviously, by the time a horse sadly gets to this stage, there's very little that we can do for it. This is the final type. This is the malevolent or malignant sarcoid. Depending on the age of the books that you read, it's one of these things, a little like most things in life, which they like to rebrand on a regular basis. So originally I think it was called malevolent sarcoid, and now we call it malignant sarcoid. This is the shoulder of a patient at the Liverpool vet school. Each of these areas that's been outlined in felt tip pen is an individual tumour. And you can possibly get an idea. Here's a very large tumour on the outside of the limb. And what's happening here is that the tumour is using the lymphatic system of the horse to progress throughout the horse. So usually the good news, if there is good news about sarcoids, is that they are contained just within the skin. They're localised to the skin. They are malignant tumours, so they are aggressive tumours, but they tend not to metastasize, that is, they tend not to spread to internal organs and to other organs. But in these very rare cases of malevolent or malignant sarcoid, the sarcoid does start to metastasize to internal organs. And it will usually use either the lymphatic system or it will use blood vessels to move around the body and set up tumours in remote areas. This horse, I think Derek said, they stopped counting when they reached 400 tumours on this horse. And again, unfortunately, there's nothing that you can do for a horse that has such an advanced case of sarcoid, and so sadly this horse was euthanized. When I first started doing these talks, this was the only photograph. This is one of the standard photographs you'll see in textbooks, or if you look on the internet for malevolent or malignant sarcoid, because they are very rare. And so, I asked Eric whether I could use the photograph, and he very kindly said yes. And that was until a few years ago when I came across one. So now I've got my own photo, which I also use. This is a horse that we've got under general anaesthesia. It's a mare. So we're just looking, this is one of the mare's teats here. And you can see we've got these very unpleasant, very irregular masses of tumour associated with the lymphatic area around the mammary gland. We did laser surgery on these. I think we caught them at a relatively early stage. Here we are sort of midway through the surgery process. And I'm glad to say that the mare did extremely well. And as far as I'm aware, she's still in remission. So that's malevolent or malignant sarcoid. I must have seen, well, certainly well into 4 figures in terms of sarcoid cases, and I've only ever seen 3 of these. So they are very, very rare, 0.3%, I guess that makes, in terms of numbers of sarcoids, but they do sometimes occur. But I guess this is sort of the worst case scenario that you could get to. Okay, so that's a little bit about sarcoids in general. Mark.
Jeremy, sorry, a quick question. The photos that you showed of the lymphatics next to the udder there, the sort of nodules look irregular below the skin. Is that more of a feature of the malevolent type of sarcoid rather than fibroblastic?
This kind of very irregular shape that we get to these tumours is certainly characteristic of malevolent or malignant sarcoids, or of other very unpleasant tumours as well. So for instance, carcinoma often looks like this as well. And some of the other more aggressive fibrous sarcoma type lesions that we see. Generally, whenever I feel things which are in chains, I always feel rather uncomfortable with and feel are going to be quite a challenge, and things which have a very irregular shape to them as well. I always feel also have a relatively poor prognosis often, or we need to be very aggressive in terms of treating them. Yeah.
Thank you.
So as I said before, wherever we find horses, we'll find sarcoids. Not just horses, ponies and donkeys, any equids potentially. I've seen them in zebra, for instance, in East Africa and also in South Africa. So any type of equid potentially. Here in the UK, the prevalence of sarcoids is around 7 to 9% of horses will develop them in their lifetime. So that's a very significant number of horses. It's the most commonly encountered tumour of horses and makes up about 30% of reported tumours in horses. And sadly, it's the most common skin-related cause of euthanasia in horses. Now, I don't think things are quite that bad. Certainly it's not quite that bad for Andy and the team here in terms of what they get up to. And it's not quite that bad with sarcoids either. But hopefully, as you'll see from the next slides, it will illustrate just why euthanasia is sadly one of the options that are sometimes considered for cases of sarcoid. First thing here, well, so what's the well, obviously the problem here is the sarcoid, but in terms of you as an owner and for the horse, what are the problems here? Yeah, tacking the horse up. This is exactly where you're going to put the tack and so on, so this is going to cause problems in you being able to use the horse. And that's, for most people anyway, is the reason that they've got the horse in the first place. If you can't tack it up, you can't work it and ride it, then the horse just becomes a very expensive lawnmower, doesn't it? What else do you think is an issue here? Flies, yeah, secondary infection, irritation for the horse. The horse will probably be aware of the fact that this tumour's there, it may well be painful as well. And if it continues to grow up the way here, at some stage it may start to interfere with the animal's sight and so on as well. So you can see, a graphic illustration as to just what a problem they are. Cosmetically very ugly, but also an issue in terms of being able to work the horse. Sadly, periorbital sarcoids around the eye are very common. Again, it's one of the predilection sites, one of the sites that we find sarcoids in very commonly. Hopefully you can see in this photograph, certainly the people at the front probably can you see that there are flies clustered around this sarcoid? Yeah. And as I say, when I did my work at the Royal Veterinary College for my Masters, we were looking at fly transmission. And probably one of the reasons that the eye is a favourite site is that this is an area that flies will commonly come and feed, regardless of whether there's a sarcoid there. There's tearing and so on that's attractive to flies. These are face flies, which, as the name suggests, will infest the faces of horses and other livestock animals as well. So here, obvious problems. You can see that the eye is partly closed because of the pain and discomfort of the tumour, and also the tumour is just physically disrupting the anatomy of the eye as well. We've got the problems of flies feeding and congregating around here, which of course will be distressing to the horse as well. It's clearly painful. Clearly by this stage as well, this will be affecting the horse's ability to see. I saw this case many years ago in South Africa, actually when I was doing that master's work, and we were gathering flies. That's a whole nother story for the work that we were doing and gathering DNA from them. And at that stage, really, there was very little that you could do for a case like this, and sadly this polar pony was euthanized. But the good news is, not sadly for this case, but going forward now, there are things that we could do with this case these days, and again we'll talk about that in a little while. Another horrid case, again an early case that I saw. The lady who owned this gelding had tried absolutely everything to try and gain some kind of remission, because you can see it's a very aggressive form of sarcoid. We did do laser surgery on it. We never imagined that we were going to cure it, and indeed we didn't. But we did manage to push things back into remission for a number of years, which was good for the horse and good for the owner as well. But really, by the time we get to very advanced sarcoids like this, again, our treatment options even today are extremely limited.
How long would that take to get to that level?
Well, this particular horse had sarcoids for many years, and it had all kinds of different treatment until, as I say, we used laser and got a reasonable period of remission in this case. But sometimes these, we can go from relatively small nodules to this within a few months. Certainly within months anyway. Derek Nottenbelt, who without a doubt is the world's expert on skin tumours in horses. Professor Derek Nottenbelt, OBE, I think he is these days, bless him. I freely quote Derek. I always acknowledge the fact that it's Derek, and I've spoken to Derek about quoting him, but Derek always says the one thing you can predict about sarcoids is that they are unpredictable. So in some horses they'll grow very slowly. In some horses they may not grow at all. They may appear and then stay like that for the rest of the horse's life. If I talk to enough people, there'll probably be somebody at some stage who'll put their hand up and say, I had a horse, or a friend of mine had a horse, they had sarcoids and they just all disappeared. And almost certainly that does occur. But I guess we generalise about things because that's the best way of trying to get things across to people. In general, sarcoids tend not to disappear of their own accord, and they tend to do just one thing in my experience, and that's they tend to get through that normal problem. So again, I think as we'll see as we go through the talk, prompt early treatment is definitely the way to go.
Do you think some people are ignorantly naive and it might just be they might pass it as a wart?
Yes,
and
yes.
I think they'll treat it with castor oil or Vaseline.
Definitely.
And then they think, oh, it's not going now.
Yes.
And then it progresses and they interfere with it and then it gets angry. Then it speeds up its, size.
Yes.
And then they still put off because they're so unaware of what treatments there are out there, or they're so terrified to actually acknowledge that it could be something,
Absolutely.
Nobody likes to admit their horses has got it. It's a
No.
sinister thing.
No, and I think last week there was an article out being quoted on the radio in the morning about how bad we are as a country, going to the doctor with skin tumours and tumours of our own, let alone with our horses. I think, you know, often hope springs eternal, that, you know, the next morning we'll wake up and it will have all just disappeared. So yes, I think there's a number of points there. Yes, I think the terminology warts is an unfortunate one, because warts are benign tumours of humans and other animals as well. These are not benign tumours, these are malignant tumours. This is skin cancer in the warts. So again, I think when I'm talking to owners, I never want to try and frighten, but I don't want to belittle what the condition is. I want to be realistic about the fact that this is skin cancer and a malignant form of skin cancer.
I think it's lack of awareness though, isn't it?
It is.
Unless it's actually biopsied, sometimes I think people can't really say exactly what it is.
It's true, although I think, you know, I think, you know, we're getting better at being able to diagnose them and recognise them. Yeah, I think so. And I think, you know, both the horse-owning public, you know, there's lots of great ways of learning about things these days with the internet and magazines and so on and so forth. I think people are becoming more proactive, and I think as a profession as well we're getting better, and I think we're much less inclined to belittle things. But there still are practitioners out there, sadly. There was one last year actually who was taken to court because the sarcoid had appeared over a joint. He kind of belittled it with the owner and said, "There's no point doing anything with that." Of course, it got much bigger, and eventually the horse was no longer being able to be worked and so on, and so it was the wrong advice, just to belittle things. I think the other thing which you mentioned there, which is also important, is kind of tinkering around with these things is definitely not the way to go. Some kind of prompt, well-validated treatment is the way to go, without denigrating anything that you might find in the back of a horse and hound. You know, things that you can generally buy, you know, on the internet through, you know, some adverts at the back of My Little Pony or whatever, is not actually going to cut the mustard, and in many cases will actually make things much worse. A little bit later on in this presentation, there's a photograph of an extremely large sarcoid, which have been treated with, and I'm happy to mention the name of it because they don't want to come after me, they're more than happy, Camrosa, literally Camrosa, and I know Derek's very outspoken about Camrosa too. I've seen a number of cases which were treated with Camrosa, and almost immediately things have become much, much worse.
I've heard people using aloe vera as well, and it speeds it all up, doesn't it?
Yeah, generally I think, you know, one of the other things about sarcoids is if we can avoid biopsying them, we will avoid putting a needle into them or a biopsy punch, because very often tinkering around with them will just make it come much more aggressively. So I think if we do that, very often we can recognise these things, I think, these days just on sight. But very often if we are going to biopsy or to take a sample from it, we need to be ready to do something really aggressive with it very soon thereafter.
I think another problem with sarcoids though is to do with the insurance policies we have with our horses, because I know a couple of owners that refuse to get them diagnosed until they get big, because they know that once the vet diagnoses them, that's the starting point for the cover on the insurance, and then obviously in a year's time they'll exclude them. So they think, well, I'll ignore it until it's quite large, then I'll get it treated, then it will be covered. But of course, it doesn't always work like that, does it?
No, it doesn't, and unfortunately, again, the data that we have, and again, the data that I'll present to you later, shows that the earlier you intervene, the better the long-term prognosis. So although it might be sort of expedient, as you say, in terms of sort of insurance, probably in terms of, you know, the patient's long-term well-being, and actually yours as an owner in terms of walking out at a later stage, you're better actually to do something with it at an early stage when it's small and treatable.
With something like this though, it is a shortcoming in the policies that we have, because sarcoids, like you say, you know, they may never come back, they may come back and everything, and I think it's wrong that we have policies that we pay for that say we're not going to cover you now because you have them. And I mean, I know obviously it's not a forum for here, but it does make a lot of people back off actually having them treated because of the expense involved in treating them.
Absolutely.
And they won't be covered by their insurance.
Yeah, no, absolutely. You know, insurance.
It's a shame.
You know, sometimes insurance is a good thing, I suppose, because sometimes it emboldens people. They think, well, you know, the horse has got £5,000 in the piggy bank, I might as well get something done with this condition. But sometimes, as you say, the cut-off points and so on, the fact that the clock tickings after a year and so on, it sometimes does confuse things a little bit. Yeah. Okay, so we've seen sort of all the bad news, so let's have a look at what we can do. going to put all of this up straight away, so you can see it's a pretty big list. I suppose a big list is a double-edged sword, perhaps. The first thing about a big list is that it suggests that you've got plenty of options, which is a good thing. But the fact that we've got a very big list suggests that no one thing is universally successful. So we haven't got a sort of silver bullet here that's going to treat everything perfectly well. But it's certainly a much longer list than we used to have perhaps 5 or 10 years ago, and so that's definitely a good thing. I'm not going to go through everything in great detail. We'll look really, I suppose, just at the subheadings here. We've got types of chemotherapy, so the use of drugs effectively to try and treat these things. A lot of you, I'm sure, will be familiar with the technical term is AW4-Ludase, which is liverpool cream, the cream that's put on prescription from the Liverpool University Veterinary School. It's a cytotoxic cream, that is, that it destroys tissue in a relatively indiscriminate way, but it can certainly be very effective, and for decades it's been the mainstay of treatment for sarcoids. Cisplatin, it's another form of treatment that we've borrowed from human medicine. We can inject it into lesions, or we can get small beads which we can sew in during surgical procedures. It can be quite successful at times. It's relatively expensive. You can only really get the cisplatin beads from the United States, so they have to be imported in, and it's very unpleasant stuff to handle. It's potentially carcinogenic in itself. So for us as vets and surgeons, we need to be very careful when we're handling it. And I think these days there are better things to be used than cisplatin, but it can be useful in some circumstances. 5-fluorouracil, again, it's a human treatment used for skin cancer. As I mentioned before, I spend a fair amount of time each year in South Africa. South Africans, buying the stuff as if it's going out of fashion, because obviously skin cancer is a big issue there. And it can certainly be effective on smaller, more superficial tumours, but not really for larger tumours. Acyclovir is a relatively well-known drug in human medicine. It's the same stuff as Zavarax, which is used for treating cold sores. And the reason that we use it is, as I mentioned before, we have a very strong suspicion and plenty of evidence, really, that there is at least a viral component to this disease. And so acyclovir is simply an antiviral drug. It's been developed by the University of Vienna Vet School, with whom I've been collaborating for a number of years now. And they now produce it in a horsey-sized version instead of a little tiny tube like this. It comes in a big 125 ml tube, which is formulated to stick relatively well to equine skin. Again, it can work very well on those very early lesions, things like a cold sarcoid. Remember, we looked at those areas that look like ringworm on the brisket of a mare. At that stage, acyclovir could work extremely well. It's very non-invasive. It's not a cytotoxic cream. It doesn't sting or burn when it's applied. You could very safely handle it on your fingers, although we always advise people from the health and safety point of view to wear gloves. But as I say, it's the same stuff as Zavarax that you rub around your lips, for instance.
Is there any chance that could have any sort of negative effect if people haven't bought cold sore cream stuff?
No, it is the same thing. And for instance, I did have a client, and she was a pharmacist, and so she was able to get, albeit little tiny tubes of acyclovir, but very, very cheap through the pharmacy. And so, I quoted her for a big tube, and she said, well, actually, I could buy whatever it was, 12 small tubes for a little bit less than that, so I'll use that. So no, that would be absolutely fine. But generally, the tube is a bit too big, really, to be buying small 5 or 10 ml tubes. You need rather more. But no, you'd be quite safe to use as long as it's proper acyclovir. Again, always be very cautious about using things that you buy over the internet, because you never be too certain what it is that's coming to you. So acyclovir can be very successful. It's now become almost a regular part of post-surgery treatment for me when I'm using laser surgery. I always advise people after they've had the laser surgery that we can just edge the prognosis a little bit further in the patient's favour by using topical acyclovir onto the wound bed. I've got some students working with me this year to try and actually work out the numbers. How much of a difference does it make? And certainly the numbers that we're currently coming up with are that it does make quite a big difference. We've been looking, for instance, with red wings, we work a lot with red wings, and we're looking at a study there where we've got very good results from doing laser surgery on its own, but in the cases where we've used acyclovir as well, we've actually got 100% remission rates. So I think acyclovir is a very good drug and very useful. We'll spend some time talking about mitomycin. We'll look at some photographs and so on of cases with mitomycin. Suffice it to say at this stage, it's another a drug that we've borrowed from our human oncology colleagues and certainly shows a lot of promise as well. Immunotherapy is where we try and stimulate the immune system to try and do something about the tumour, to try and get rid of it. One of the problems is that horses don't produce an immune response to these tumours, or indeed to the virus that we believe is associated with the tumours. So unfortunately the horse isn't doing anything to try and help us to get rid of these tumours. Normally you would expect an animal or a human to produce some kind of immune response to a tumour. But as I say, horses don't seem to. So these are ways of trying to stimulate the horse's immune system to try and give us a bit of a hand. Again, sometimes they can be successful, but generally they're rather indifferent in terms of the results that we get. Radiotherapy, this is what's being done. This is a horse from the Animal Health Trust. These are basically radioactive sources, these rods, which have been threaded in a very careful, mathematically worked out way through the tumour to give a very regulated dose over a period of time. It can be very successful. It tends to be reserved for these very problematic tumours around the eye, and the reason for that is it's hideously expensive. It's sort of £5,000, £6,000, £7,000 per tumour to treat. You can imagine the horse is radioactive whilst it's being treated. All of its waste products are radioactive, so they all need to be disposed of in the correct way. And so it's a very expensive technique. There's only a handful of places that offer it. There's a referral centre in Newmarket, Rochdale's offer it these days, Animal Health Trust and Liverpool University, and I think that's it. And they all have waiting lists. So it's beyond the standard payout for insurance would be £5,000. So usually it's above that. So it's often over most people's reach. Yeah.
Going back to immunotherapy. I was wondering why their immune systems don't have a response.
Yes, it's a good question. It's one that we don't really know the answer to. We've got some idea as to why that is. The virus, if indeed the virus is involved in the disease, and as I say, I'm certainly a big fan of that theory. I'm certain that the virus is involved. For instance, the fact that we can use an antiviral and get very good remission in some cases, to me, kind of proves it. The virus, we know, is able to fool the immune system into thinking that it should really be there, and also is very good at combating the immune system in general. So that's probably part of it. In cattle, as I say, it is a cattle virus that we believe is involved. Cattle also produce similar type tumours, but they resolve. The cattle do produce an immune response both to the virus and to the tumour. But cattle have probably co-evolved with this virus for tens of thousands of years, and so the immune system has managed to, if you like, sort of key into the virus, whereas it's probably much more recent that it started to co-infect horses, and so horses' immune systems just don't seem to have been able to get to grips with it, really.
Is there any way we can take the antibodies or whatever we can from cow and manipulate them more?
Yeah, no, it's interesting. People have tried that. They've tried taking antibodies and injecting them into the horses, and it doesn't seem to have any effect whatsoever. There are people working on vaccines in horses, several groups through the world, and I know one of the groups really well, and they are actually having good success with vaccines. That being said, I don't think a vaccine will be commercially available for many years, because it will take a long time for it to go through clinical trials and so on. But they have found ways of boosting the immune system to try and recognise the virus. But in the normal horse, unfortunately, the horse just doesn't seem to recognise it. So by using these ways of boosting the immune system, basically BCG is the human vaccine for TB, and it's sort of very immunogenic. It stimulates a very strong immune response in the patient. And what we do is we inject it around the tumour, and it gets the immune system, if you like, to gather around that area, takes a really good hard look at it, and hopefully, or we believe, the immune system actually then starts to recognise the fact, oh, there's not just BCG vaccine here, there's actually a tumour sitting right next to it. We don't entirely understand how it works, but it's something along those lines, yeah.
Can I say something? My horse had sarcoids and was treated very successfully by the vets here. 2.5 years now, he's been in what you call remission, where there's been no sign. Since and after the treatment, I made the decision to put him on, because I actually think it's an immune, the body doesn't recognise it, so that it allows to invade, and the body still doesn't recognise it, like it's just not recognised the signal, it's been invaded. So my horse is on echinacea route,
Yes.
well, intermittently, then he comes off, and he goes on something that helps purify the lymphatic system, I think cleavers and milk thistle and other stuff that feeds that, and turmeric.
Yes.
And so far, so good.
Certainly, you know, a lot of owners, you know, are keen, I think, to try and do as much as they can as well, and use alternative or complementary therapies and so on. Yeah, I can't point to any hard and fast evidence saying that it works, but there you go. I certainly.
But in my incident, I think so.
Exactly, and I speak to lots of people who have good anecdotal evidence that they believe that it helps. So I always say to people, there's no harm in trying, and if it is having an effect, then that's great. The only things, as I said, that I would categorically say to people don't use would be things like Camrosa, for instance. You know, because I have seen for myself that it makes things worse. Yeah, but I think things which may help, there's plenty that we don't know. Certainly doing things like that, you know, that's something the owner wants to try and do. No reason not to do that. Yeah. So yes, that's radiotherapy. Expensive, but good remission rates generally with it. But again, there are other things that we can do where we can get very similar remission rates. We would get remission rates of 90+% using radiotherapy generally. But there are now other treatment modalities that we can use where we would get very similar results at perhaps not a fraction, but far less cost. Photodynamic therapy, again a technique, as I said, that we borrowed from human medicine. We'll talk about it in a little bit more detail, so I'll whiz past it here. And then, of course, surgery, ways of cutting the tumour out. So in the past, we would use sharp excision, just take a scalpel to things and cut it out. Can be very successful, but sometimes associated with higher recrudescence rates, higher rates of the tumour coming back than other techniques. Cryosurgery used to be very popular. It's the use of cold, effectively, to freeze the tumour off. I think over the counter at the chemist you can buy kits to cryo your warts and verrucas off these days. So it's just the same thing, but on a rather larger scale. Very popular sort of back in the 80s and 90s. It's lost favour a little bit now because, again, the remission rates aren't fabulous with it. They're not awful, but there are probably better things out there. And it's quite a painful thing to have done, particularly for more extensive tumours for the horse. Laser surgery, again, we'll look at in just a minute, so I won't spend any time really talking about that now. Right at the bottom in bold, in yellow, jumping out of this, multimodal therapy, so using lots or several different approaches for one single tumour definitely is associated with better remission rates. And we know that from human oncology. If you were unfortunate enough to have a tumour, it's very unlikely that you would just have a single form of treatment. In all likelihood, it would be multimodal therapy. So you might have surgery, but then you might have chemo, and you might have radio as well. So again, there's no reason that we shouldn't be doing this with our patients. And going back to the question about insurance, I guess this is one of the good things about insurance. They're quite happy to pay for multimodal therapy. So I've never had any problems with any of the techniques that I'm talking to you about this evening, getting insurance companies to agree to pay for it. I've never had it even questioned as to whether they're going to. They're quite happy to accept the fact that multimodal therapy is the way to go to get better results.
Excuse me, can you just go back a minute?
Yes, of course.
You know, for the cryosurgery, where you said it was sort of use the freeze method.
Yes.
Is that something that you would do in a small sarcoid or in its infancy?
Yes, it would be more effective in smaller sarcoids. One of the problems with cryosurgery is that the cold, when you put the source of cold effectively onto the skin and onto the tumour, will only penetrate so far. So if you've got a larger, fleshier, deeper tumour, it may not penetrate all the way to the base of the tumour, and so it may require repeated treatments to be effective, and therefore it probably is much more effective on smaller, more localised tumours. Yeah.
Okay, thank you.
So here we are doing some laser surgery, very jazzy pair of scrubs. I was obviously in a good mood that day. So why do we use carbon dioxide lasers? This is a carbon dioxide laser here. It's just as you would kind of imagine from a James Bond film, really. It fires a laser beam, which does the cutting. They're used again commonly in human oncology for human tumour surgery, and these would be the reasons why. First thing is that we tend to get reduced inflammation when we use lasers. The reason that we get inflammation after doing surgery very often is because as soon as you cut into the skin, as you imagine, it starts to bleed. And then, of course, that's a problem both for the surgeon in terms of being able to see what you're able to do. Yeah, so we could cauterize it, or we can use artery forceps and various instruments to try and crush vessels, and we can use swabs and so on to dab it. But all of that fiddling around with and handling the tissue is traumatic to the tissue. And that's one of the reasons that we get swelling after surgery. So if we can minimise that, then we'll get much less post-operative edema and swelling. The beauty of the laser is that effectively, as it's cutting, it will seal smaller blood vessels, not huge blood vessels, but smaller blood vessels will be sealed as it cuts. So very often we can have virtually bloodless or indeed bloodless surgery when we're using the laser. And therefore, as I say, we have less handling of the tissue, shearing and tearing and so on, and so less post-operative edema. One of the other sources of swelling after surgery is the lymphatic vessels and the accumulation of lymph at the site as well. And again, the laser will seal lymphatic vessels as it cuts. So again, we get less swelling from that source. The laser cuts at about 95 degrees Celsius, or just above 95 degrees Celsius. So you can imagine it cauterizes the wound very effectively as it cuts as well. So we don't really have any problems with secondary infections. They're very rare, again, as you'll see from the data that I'll show you in a minute. And also, if we are believers in the theory that there is a virus associated with this disease, and as I say, I'm a big fan of that, it's also going to, of course, destroy any viral infected cells or virus particles that there are present at the wound site as well. Another problem associated with using a tumour, with using a scalpel to take out a tumour, is that potentially, as you're cutting the tumour out, if you touch the tumour or any areas where there are tumour cells, you can pick them up on the scalpel blade, and then as you continue to cut and do the surgery, you can end up what we call seeding those tumour cells elsewhere in the wound bed. So it's not unusual to see where a tumour's been cut out. You'll have a nice circle in the middle where the tumour was. There's no longer a tumour there, but all around the periphery where the scar line is, you can see that there's new tumour beginning to bubble up, and that's because it's been seeded. The beauty of using a laser is that there is no scalpel blade involved. The only thing that's actually doing the cutting is a beam of light. So we don't have any problems with seeding tumour cells, and anything that the laser beam comes into contact with is vaporised. As I said, we get good hemostasis, so good control of bleeding when we're using the laser, cauterising small vessels, and that also, because we spend less time faffing around trying to staunch the flow of blood and so on, it cuts down the surgical time, which is good for the patient. And also good for you in terms of your bank balance as well, because hopefully that makes things less expensive. It's a very accurate tool. The laser beam itself is just a fraction of a millimetre across, so you can certainly conduct extremely accurate surgery using it. Here we are using the laser. As you can see, this is the neck of a horse where we're taking a sarcoid off. A few things to note. As you can see, there's no bleeding. You've cut through the skin, but there's absolutely no bleeding there. There's a minimal amount of instrumentation being used. This is the tip of the laser here. This is just a guider. It's just to give you a reference point as to how close to the skin you need to be. In this case, all I'm using is just a set of tissue forceps just to retract the skin. So a very nice way of doing surgery. Other benefits of using the laser, certainly human patients who have both laser surgery and sharp excision, so surgery with a scalpel, they tell us that they have much less post-operative pain after having had laser surgery than after having had sharp excision with a scalpel. And certainly from my experience, horses seem remarkably comfortable after having laser surgery, and often even after very extensive surgery like this, here we are just a few weeks later, you can see that things are healing up very well, and usually the horses seem to cope extremely well, even with really large deficits being taken off. And we think that's probably because the laser, instead of leaving raw cut nerve endings, it again seals nerve endings as it's cutting. That means that we have to use less pain-killing drugs for the horse, which is good for the horse, also again good for you in terms of cost. And it also means that a lot of the surgery that we can do standing, rather than having to knock the horse down. And there's always a risk involved, as you know, in knocking horses down for general anaesthetic. A lot of things we can get away with doing standing, which is, again, good for the horse. All of those things add up to the fact that there are good post-operative benefits, so horses generally are hospitalised for very short periods of time. Standing cases go home the same day. GA cases generally go home the day after the surgery, and only really stay in the night of surgery because of the general anaesthetic risk, not because of any problems associated with the surgery. Get very rapid healing. We'll see that in some of the photos as we go through some cases. And as I said before, we tend not to use as many antibiotics as we might do for other forms of surgery, and we don't need to use as much bute or Danolon or other painkillers as well. Hopefully it all adds up to reduced costs for the owner, and hopefully high levels of customer satisfaction as well. I won't go through all of the details on this, but again, it's just to illustrate the fact that a large number of cases we can do just as day patients. They'll just come in and see us for the day. We'll use standard sedation techniques to do the surgery. And basically the post-op care is usually very, very simple for these cases. It's usually a 5-day course of antibiotics and bute or Danolon, and what I refer to, hopefully not too cavalierly, but as benign neglect. We don't dress the wounds, we don't need to clean the wounds particularly or faff around with them. They heal up extremely well just with benign neglect. Okay, now just going to have a look at a survey that we did last year, looking at how do these things work and what kind of results do we get. We did a survey of 68 patients which were referred from a single UK practice in Essex. They were surveyed in March of 2012, so just over a year ago. It was a random selection of cases from their computer database, and we had 67 horses or ponies in the study and 1 donkey as well. And basically these were the owners that responded in a timely fashion when we wrote to them and asked whether we should survey them. We had a split of 28% mares and 72% geldings, which is quite interesting because certainly in the literature it suggests that there is an over-representation of male, as on particularly gelded animals, in sarcoid patients. And one of the reasons for that, again tying up with this thought that there may be an infectious cause, is that when the animals are castrated, perhaps the infectious agent at that stage manages to enter into the horse's system. And again, that ties up with the fact that very often one of the predilection sites for sarcoid is indeed around the groin and the inguinal area of the horse. So this data, very nice, it ties up with the kind of data that we see in other papers for the spread of mares and geldings. The majority of our patients were younger, sort of aged between 6 to 10 years of age. And again, this fits in relatively well with what we know about sarcoids. The peak incidence of sarcoids is usually referred to as being around 6 years of age. So it's a disease associated with younger horses rather than older horses. Generally, we think of cancer and tumours as being associated with increasing age. This is an exception to that rule. It's generally younger horses, not exclusively, but generally younger horses that seem to be affected. And again, that seems to tie in with the idea that there may be an infectious cause, suggesting that younger horses, their immune system is much more naive to the possibility of being infected. I think the reason that our patients were generally rather older than the 6-year-old 6-year-old sort of average that's usually quoted is because this was a practice very much associated with competition and sports horses. So most of the horses at the practice were older horses, as opposed to a practice which does an awful lot of stud work where we might have been seeing younger animals. 15% of our patients had a history of some prior treatment. So these are just veterinary short links, history and treatment. So 15% of them had some form of treatment before we saw them. Our patients were treated from August 2008 through to September 2011, so effectively between 6 months and 42 months after the operation we were following them up. All of these patients were just treated with laser surgery alone, so not using any of the chemotherapy adjuncts that we talked about. This is just straight laser surgery. We got the data both using the records which were taken at the time from the veterinary practice, so looking through their computer database, and then the owners were surveyed by telephone, not by myself, so they didn't feel that they had to say anything that they didn't want to say, by an independent researcher from Nottingham University who gathered the data for us. And these are the results that we got. So I guess sort of the headline result, the one that everyone's most interested in is, were the patients, I'm hesitating to use the word cured. I think we're, for reasons that we'll talk about in a minute, we're always a little reticent to talk about curing cancer patients. I think we usually talk about being in remission. So we had very good remission rate, 92%, at the site of surgery. So where we took the tumour off, in 92% of cases, the tumour did not come back at that site. Again, this fits in very nicely with suppositions that they've been before, but I don't think anyone's actually produced data to show this before. It's always been assumed and felt that prior treatment failures reduce the subsequent prognosis for other treatments. So if we've used something first which hasn't worked, the next treatment that we try is less likely to be effective. And certainly that's what we found as well. So in cases where there had been prior treatment which was unsuccessful, it halved the prognosis going forwards for the patient. So I think the take-home message of that is to use something that's likely to be successful first time round. So again, it goes back to your question about using half measures and dabbling around with these things. We need to be aggressive when we treat them, and we need to use some kind of treatment which has good data behind it and good validation. Horses went back very rapidly to work. 57% of the patients were back in work within 1 month. And actually the researcher, the student who did the survey, the questions were framed, did your horse go back into work within a month, within 2 months, 3 months, then I think 6 months, and then 12 months. And the researcher said, really, you should have had, did your horse go back into work a week, 2 weeks, and so on. She said you should have broken down that first category down into weeks, because most people were saying, yeah, well within a month. So these horses do extremely well after the surgery is the take-home message here. They heal up very quickly. For me as a surgeon, I'm very lucky to work with horses, because generally they are very forgiving surgical patients and their skin heals extremely well. And the laser seems to be a very good treatment in terms of doing surgery. The skin seems to react extremely well to laser work. 23% of the others went back within 2 to 3 months, so the vast majority back in work very, very quickly. Very low rate of secondary infection, that's the bar here. As we said, the laser cuts at over 95 degrees Celsius, so therefore you expect that it's cauterizing very effectively as it's cutting. Those that we did have secondary infections responded to short courses of oral antibiotics. And even if they did develop infections, it seemed to have no influence on the speed with which they returned to work. 87% of the clients were satisfied, 66% said that they were very satisfied, and 21% said that they were satisfied. And I guess these numbers kind of tie up quite closely with whether we got remission, as you would expect. So in those where tumours did come back, why did they come back? I thought this was quite interesting actually. We seem to get an even distribution of reoccurrence right the way through the survey. So it wasn't necessarily that the tumours would come back immediately after the surgery. In some cases they came back, you know, many years after the surgery. So I thought that was quite interesting and wasn't necessarily what we expected. And so therefore I think, you know, it's advisable to talk about your horse being in remission rather than cured. And I think it's right to be a little bit more cautious, and I think generally our human colleagues in oncology would also talk about patients being in remission rather than cured forever. And I think also if we talk about that, then it means that owners will continue to be vigilant with their horses. Hopefully this is an end to it. As I say, we were getting very good remission rates, but nevertheless, once a horse has developed sarcoids, even if we're successful at the site of surgery where we've done the surgery already, there will always be the risk of them developing sarcoids elsewhere. So it pays for the owner to continue to be vigilant and to look out for new tumours. Didn't seem to be any difference in terms of recrudescence when we looked at mares and geldings. These were the significant factors that we found which were affecting why tumours seem to be coming back. We've already talked about the fact that if we've had some previous treatment which hadn't been successful, then that halved the prognosis for patients. And again, that's something which we've always felt was the case, but here we are actually putting some data to it. Cases like this were also associated with more recrudescence, and again, perhaps that's not a surprise. So horses presenting with multiple sarcoids were more at risk of recrudescence. One of the things that we wonder is perhaps when you have cases like this where the disease is almost out of control, is it a rather more aggressive form of the disease? Perhaps is it a more aggressive form of the virus? And that's why these horses are developing these very proliferative, very aggressive lesions. So satisfaction numbers again, 87%, as I said, fell into the satisfied category. Didn't seem to relate to whether the horse developed any scarring. We've got 45% of cases there was some scarring, and as you would imagine, that was associated very much with the size of the tumour that the animal first presented with. So you're not going to get rid of something of this size without some scarring, I'm afraid. And we'll go through the sequence of photos, and you can see, I think the scarring is acceptable. This is a lesion that was treated with Camrosa. It started off about the size of a 50p piece, and within 3 months of being treated with Camrosa was that size. So there you go. If there's anyone from Camrosa who wants to take me to court, that's fine, bring it on. I'm through this. So here's the horse immediately after surgery, just standing surgery in this case, just in stocks. And here we are, I think 3 months after the surgery. So it's knitted very well together. Sure, you can see that it's there, but it's a lot better than that, I think you'll agree. So yes, obviously depended on the size of the tumour as to whether we got scarring at the end. This is a fair-sized tumour. Here we are immediately after the surgery. Here's the horse just 3 weeks after the surgery. I was going up to our big annual equine veterinary bash, and was going to be presenting about some laser surgery and sarcoids, and the referring vet phoned me up and said, have you finished your presentation yet? And I said, well, I have, but could we stick something else in? He said, well, you should go and see Soldier, this is the name of the horse. He said, because I think you'll be quite impressed, you'll probably want to put the pictures in your presentation. Here he is 3 weeks after surgery. So you can see in some cases, as I say, when we've got smaller tumours, particularly the sheath is a very good area to operate on. Soldier might not have agreed with me, but we've got plenty of spare skin there. It's also very well supplied with blood, and so it does heal up extremely well. It's a very common site for tumours to appear at, so in some ways that's very good because it's a great place to do surgery on. So yeah, I think that's a great result, isn't it? Just after 3 weeks, just a tiny scan, that came away. That was one of the very first cases I did with my very first laser. So 8 years ago, and he's still firmly in remission and happy as Larry. So I think it's important that we talk to clients about whether there may or may not be scarring, and just inform you as to what's going to happen, so you know what to expect after the surgery. In other studies of laser surgery, sometimes they'll report that they have white hair growth come back, as very often you do with any kind of wound on horses. I have to say that in the 8 years that I've been doing this, I've never had a client come back and tell me that they've had white hair growth. I always tell people that it's possible, particularly if it's a valuable show animal or something like that, but as I say, I've never had it occur. It's never been reported in any of the post-op surveys that we've done. 85% said they'd recommend laser surgery for sarcoid treatment, which again kind of ties up with our satisfied clientele. 70% thought that the treatment was value for money, and again, as you would expect, that was strongly correlated with recrudescence. And so I think, again, it's important that we manage people's expectations. So if the horse is presenting after having had Liverpool cream treatment and cryotherapy, so this is the third treatment we're going to try, the prognosis is going to be much lower for that horse. Or alternatively, it's a horse with multiple tumours. Again, the horse is probably going to have a poorer prognosis. Yeah.
Does that figure imply, or get that right,
Either, I
that
think.
30% did have recrudescence not at the site of surgery?
So no, we'd go back to the figures over way back, right back here. So yeah, 92% of our clients had no regrowth at the site of surgery. 8% had regrowth at the site of surgery. Yeah.
But what about elsewhere in the secondary signs?
Oh, okay. Yes. So that's yes, that is tied up with recrudescence at other sites. Yes. Sorry, I misunderstood the question. Yes. Yeah. So in about 25% of cases, we found that they would develop sarcoids elsewhere, but not at the site of surgery. So again, that's an important thing I think to counsel people about. Once the horse has sarcoids, if we find cases, early presentation cases, just with a single or two tumours, there is a reasonable chance of getting a very good result in terms of non-appearance of tumours elsewhere, but you can't guarantee it by any stretch of the imagination. And again, I think if we believe in the viral story and the fact that the horse isn't producing an immune response to the virus, then it's likely that the horse is going to continue to produce tumours elsewhere. Yeah. So again, I think that's important to counsel owners about that although we would be very optimistic that at the site where we're doing the surgery, that will be an end to the problem, we can't guarantee that the horse is never going to develop a skin tumour elsewhere. Yeah.
Could I ask?
Yes, of course.
When you say about the laser surgery, is there a certain size that you would say about doing that to, or would you do it to smaller ones? Because
No.
saying about often if a third treatment might not work so well,
Yep.
would you then put it off until it was bigger?
No. For me, my heart sings when I'm presented with a little tiny tumour. I think brilliant. The chances of getting rid of this are extremely high.
Yeah.
Whereas you could produce, for instance, that large lesion on the shoulder, you'd be much more circumspect really as to how successful you're going to be. And as I say, that horse is firmly in remission. That's 2 years after having done that surgery. The largest tumour I've taken off was the one, if you remember, right at the very beginning of the presentation, there was the pony there with a huge tumour on its bum. That weighed 1.1 kilos, so that's the biggest tumour I've ever taken off. And I think certainly when I first started doing this 8 years ago, I don't think I would have tackled it, but now I feel sort of brave enough to do those kind of things. And I've seen other tumours, particularly this last year, actually seems to be a year of very large tumours. Others, getting on for a kilo in size. And I think one of the things with the very large tumours, which is making a big difference, that horse with the large tumour on its shoulder, and also the pony, both firmly in remission. The pony a year and a half after having done the surgery, the other one 2 years after doing the surgery, both treated actually post-operatively with acyclovir as well. And I think in those really aggressive cases, that makes a
I
difference.
suppose ones like that happen quite quickly, like you said, was it 3 weeks the one on the shoulder?
Within 3 months have gone to that kind of size, yeah. So they can progress on very, very quickly. So yes, I think the smaller they are, the better, but certainly we'll tackle really very large tumours. But again, I'm realistic enough to say, if you have a horse which is presented rather like this horse. This was a horse that we did do surgery on, but the owner was very insistent that she wanted something doing with it. My advice to her really was that there was no chance we were going to get any meaningful remission remission in this horse. We got remission for a period of time, but not for very long. This is a horse actually that we did laser surgery on. We also used kisplatin beads. We threw the kitchen sink at it. The owner, extremely wealthy, very fond of the horse, had her own reasons, but both myself and Rebecca really trying to talk her into something that she really wanted to try.
You mentioned younger horses. Is there an age you would think that it's not worth trying?
No, I think the only thing in terms of age which would preclude them from potentially being candidates is, for instance, if they needed a general anaesthetic to have the work done and they weren't fit enough to have a general anaesthetic. So we've had one or two, for instance. I had one a few weeks ago, extremely large horse, nearly a metric ton of horse, and when he appeared he was very ataxic, very wobbly behind. And we all just kind of looked at him and said, we really want to knock this thing down. So we thought we'd sort of reassess things at a later stage. We've had some, for instance, that have been elderly and had liver problems and so on, again, where we've been very concerned about taking them for general anaesthesia. A lot of these things we can do standing though, so that again increases the age range that we can do things. And most horses, for instance, I've got a case on Friday, that's an 18-year-old horse, so that's going for general anaesthetic, no problems with it at all. So generally horses, are not quite as horrible general anaesthetic risks, I think, as you would think from looking at the internet. And I think, again, it depends where they go for general anaesthetic. So somewhere here, where the team's very experienced in doing general anaesthetic work, the risk would be far lower than in a general practice where, every now and again they think, oh, let's have a go at knocking down a horse. Those are, unfortunately, I think, the practices where they start to get a bad reputation for the profession in terms of the risks of general anaesthesia. Yes?
When you use your laser, certainly in my horse's case, it had the chemotherapy cream, and it almost came out as what they described a plug.
Yes.
And I heard the word root, and they just look like a cork coming out of my body.
Yes.
When you're doing the laser, how do you know that you're going deep enough to get it all out?
By experience, really. And I think one of the reasons that we've got very good remission rates using the laser. I presented this presentation last summer at the University of Vienna Vet School, and the very first question from the head of surgery was, you seem to get much better results than other people do using CO2 laser. Generally, other surveys of CO2 laser remission rates are sort of 70–80%.
We're not cutting enough out.
I think that is the reason, and that was my answer to him. I'm aggressive in terms of the margins that I will take. I'd much rather take a little bit too much of a margin than feel that we haven't got enough margin afterwards. And we can assess the margins, albeit after the event, by sending off what it is that we've taken off, sending it off to the lab, and they can assess and tell us whether there are tumour cells right to the very edge of where I've done the surgery, or whether we've got a margin around the tumour, and so that hopefully can put our minds at rest as well. But over the years, I guess you just develop a good eye for where you need to be taking the margins, and if in doubt, I'll err on the side of caution and take rather more perhaps than otherwise I would.
Going off on a different tangent, you mentioned South Africa.
Yes.
This is just pie in the sky, but there's a lot of sun there.
Yes, we certainly.
Do you think it's a sun factor with our horses, or?
No, I don't think it is. But
we all have to put sun cream on a lot more now, don't we?
Some tumours are. So we see more squamous cell carcinoma, which is a sunlight-related tumour, than we used to. But I don't think so with
I'm wondering if
sarcoids.
some horses are presented with fields with no shelter from the sun. People aren't putting sun creams or blocks on them, or they're not putting enough, fly sheets on them, and there's no UV protection. Maybe that's what's
I think it's certainly one of the reasons that we see more squamous cell carcinoma than we did, and certainly I see more of that. And I think most vets that I speak to say that they see more squamous cell carcinoma than they did.
And if it's fly transfers, then maybe we should all as also be putting fly hoods on our horses.
I think certainly if you feel that there is a risk of it being, so for instance, if you have a horse on the yard which has open bleeding sarcoids, something like this, where flies are going to be attracted, you might want to think about fly control for the horses which don't have sarcoids. I would certainly agree with that, yeah.
Is that the same if they're not open though as well?
I think there's less risk of the virus being transmitted if they're not open. Here, all of the surface of this will be positive for virus. and viral DNA. And as flies come and feed here, basically they'll come and feed here, then they'll have a rest, digest the meal, and then they'll look for their next meal. So if there's a horse with a small cut or grey somewhere else, and they go and feed on that, they just mechanically transmit the virus across. So horses like this are a risk to other horses potentially, and so I guess there's one of two things: either you get this treated as soon as you can, or alternatively you think of some kind of way of stopping flies from transmitting what's here potentially to uninfected horses. Yeah.
Is that just simple, like a horsefly bite, where they bite and they'll bite down and then they'll go and bite another horsefly?
Yeah, the work that we did at the Royal Veterinary College looked at what we call mechanical transfer, so where a fly lands on the tumour, feeds on the tumour, and then flies to another horse and just passively carries the virus across. We didn't look at biting flies because we didn't have the time to do it, but almost certainly if it can be mechanically transferred by infants, I think, yes, potentially biting flies can transmit it as well. Okay, so yes, the other thing about treatment, value for money with treatment, I think the other thing that we saw was there was a correlation with whether the horse had to go for a general anaesthetic or not. And as you imagine, general anaesthetic increases the cost of the procedure, and therefore that certainly coloured people's perception of the cost aspect of it. Okay, very quickly, other things that we can use the laser for. Exuberant granulation tissue, I did one of those yesterday. So we can trim back granulation tissue with the laser, seems good for that. Non-healing wounds, which very often will turn out actually to be sarcoid. This is, again, this is the abdomen of a horse. Once we cleaned it up, it looks a little bit more like sarcoid, and sure enough, once we sent it off, this turned out to be sarcoid rather than just a non-healing wound. Melanomas, do a lot of melanoma work. Again, the advice really these days, not just from me, but from Derek as well, I think when we see melanomas, whilst they're small, whilst they're operable, before they start to spread, much better to get them off rather than wait for them. Mark just showed me gosh, I mean, that horse's dog, and huge, great big, inoperable by now melanoma around the dog. It would have started off a tiny thing like this. Much better to get rid of them whilst it's
Because they go internally as well, don't they?
Yeah, they do, yes, they do. So again, this is one close to an eye, which we're just understanding, as you can see. With melanoma, it's, they tend to be less aggressive tumours, not always, but tend to be less aggressive tumours, and so generally we can take a rather smaller margin around these tumours. This is an aggressive melanoma. Very often the ones which aren't black tend to be much more aggressive. Here's the horse, this is 3 weeks after surgery, and here we are 3 months after surgery. So little stuff, but nothing much more than that. But a good result, I think. Mast cell tumours, quite common in horses. Unfortunately not as much of a problem as they are in dogs. But again, worth getting off, and a little bit difficult to tell exactly what kind of tumour this is at this stage. Again, something we can just do standing. Squamous cell carcinoma, we were just talking about, sunlight-related tumour. This is a clitoral squamous cell carcinoma. Kind of hard to imagine how the sun gets there, but not always associated with the sun, but certainly in some cases are. Again, there is a suggestion now coming out from research in the States that these again may be associated with viral infections. So some of these I've started to treat with acyclovir, and again we've had some good results actually. Here's a mare immediately after surgery, so good result. And then equine eosinophil granuloma, just slightly bizarre, non-malignant tumours, but relatively common as well. Okay, so we talk briefly about mitomycin. It's an anti-tumour antibiotic. It's produced by bacteria, and it's kind of bacterial warfare, if you like. This particular species of bacteria produce mitomycin naturally to kill off other bacteria to stop them from competing with it. And somebody very cleverly thought, well, if it can stop bacteria which are rapidly replicating their DNA, perhaps it could stop tumours from growing as well. And so it has been developed for human treatment. It's used for things like bladder, anal, esophageal and mammary tumours, and in humans it's used systemically, so it's injected into the human, into the bloodstream, and then it will target the tumour cells and stop them from dividing and multiplying. In horses we use it intralesionally, so we inject it into the tumour. for a number of reasons. The first is it's a relatively expensive drug if you were to give it in horse-sized doses intravenously. And the other thing is that it has some unpleasant side effects. And so it's better if we can just get it locally into the lesion. And so that's how we use it. This is a case from Red Wings, from the Red Wings Horse Sanctuary. And this was a case, again, where we had tried absolutely everything on Sammy the pony. So we started off doing laser surgery first on it, and this was one of the relatively rare cases where we hadn't got remission. Then we tried doing another technique, photodynamic therapy, that we'll talk about in a minute. That also didn't work. Then we tried BCG, kind of running down our long list of treatment options that we looked at before. That also didn't work. And this was the very first case that I tried Mitomycin on. So really, poor old Sammy was more or less in the last chance saloon here. And this, as you can see, an unpleasant, rapidly growing tumour right on the edge of the eye. Bad news. 2 treatments with Mitomycin, I think 3 weeks apart in this case, and that's Salazar.
Did it just fall off? Or does
Yeah,
it
basically it just goes necrotic, it just dies and just sloughs away, and you end up with this. I think the scarring here that we've got was more associated actually with all those other treatments that we've done rather than with the Mitomycin. As I say, first case that I treated just over a year ago, be about 14 months ago, I think, that we treated Sammy, and I saw Sammy on Monday at Red Wings, absolutely no sign of the tumour. So a great result. So in certain cases, this can work extremely well. So it's a very useful thing to have up our sleeve, I think. This is another one, early tumour that I treated. This is looking into the axilla, into the armpit of a horse. And this cluster of tumours, as I said right at the beginning, the clusters of tumours and chains of tumours, never really a good presentation. The axilla, you certainly do lots of laser surgery in the axilla, but it's a difficult area because obviously there's a lot of movement there, so it's slow to heal. And this was a very extensive area. I mean, this is an area of tumour much bigger than my fist. So we thought, well, let's just have a go with some Mitomycin and just see whether I was thinking perhaps whether we might just reduce the area of tumour that we then had to do surgery on, and then reduce the deficit that there was going to be after surgery. Injected with Mitomycin. Here we are during the reactive process, so this is what you would expect to see. You can see the tumour just split up and it's becoming necrotic and just beginning to fall away. And I guess importantly at the wound edges and underneath you can see there's nice healthy tissue coming back here. And here we are at the end of the process. So there's some scarring there. There's some white hair growth, slightly bizarre sort of mark of Zorro which goes from the axilla up onto the brisket. But the owner absolutely fine with that, much better than having a big fist-sized tumour inside the axilla, which was certainly restricting it. It's a very nice horse, dressage horse, certainly restricting its ability to work. And again, still firmly in remission. This was an early case that we did, so again, this will be about a year down the track. So, so a very useful drug. Certainly doesn't work in all cases. Again, I've got a student looking at remission rates. I'm thinking remission rates are going to come out probably more like sort of 60%, something like that for Mitomycin. So it's not universally successful. Seems to be particularly good for lesions around the eye. I think the success rate around the eye will be much higher, but a good drug and a useful thing. Right, final thing we're going to just very quickly whiz through is photodynamic therapy. Human treatment, used for skin tumours in humans very widely. Used particularly for basal cell carcinoma, which is the most common form of skin tumour in humans, and also for squamous cell carcinoma, which is called Bowen's disease in humans. Basically, the technique uses photoreactive dyes. So these are particular types of drug, if you like. It's like a prodrug, which reacts to light of a particular wavelength. The drug that I use rejoices in this ridiculous name of methylaminolevulinate, known as MAL, or the trade name for it is Metvix. As I say, it's a prodrug which is activated by light. This is how the protocol works. What we do is we apply the drug to the wound, and either we'll apply it either to an area that we've done surgery on to debulk the tumour, for instance, first, or alternatively just straight onto the tumour if it's a more superficial sarcoid. And then we put on a dressing which stays in place for 3 hours, which gives the drug a chance to soak through, if you like, into the tumour and get into all of the tumour cells. Then at the end of that 3-hour period, what we do is we illuminate the site with a light which produces the particular wavelength of light which is going to activate the drug. And so here we are doing that again. This is at Red Wings, just illuminating the area. And what that does is it activates the drug to destroy any cells that it's intercalated with. So any cells that it's gone into become destroyed by the production of reactive oxygen species and other things that destroy cells. Usually it requires 2 or sometimes more treatments, generally 2, that's the standard human protocol, usually a week to 2 weeks apart. As I say, generally will only work for more superficial tumours and or for tumours that we've debulked. So you'll see in this case, this is a horse where we're obviously treating a tumour over the eye. The problem with doing surgery for this particular horse was that we couldn't get enough of a margin because of the eye itself. It was so close to the eye, I knew I wasn't going to get all the tumour out. So we wanted something else, once we got rid of most of the tumour, to get rid of all of the tumour. So this is very useful for that kind of presentation. Yeah.
Is there a worry there that other cells around it might also absorb the dye?
No, that's one of the nice things. I mean, we were talking earlier about sort of the silver bullet. To a degree, this is kind of a silver bullet because it's only taken up by rapidly dividing cells. So it's only it seems to be very targeted really for tumour cells, which by their very nature are rapidly dividing cells. So no, it is actually very specific and almost seems to seek out the tumour cells at the site where it's applied, and normal skin isn't really affected by it. So it is actually a very neat treatment.
Is it safer than the radiation treatment?
Much safer than radiation, or for instance using livable cream or something like that, which is pretty indiscriminate.
They're greedy cancer cells.
They are, yeah, which is fortunately their sort of downfall, both in terms of using this and also in terms of Mitomycin, which is also targeting cells which are replicating. Yeah. So here's some examples of using this technique. Again, this was a very early case that we did. This is a 21-year-old Arab stallion. This is squamous cell carcinoma. So this is a good type of tumour really for photodynamic therapy because they tend to be rather more superficial tumours rather than great big fleshy tumours. As you can see, it's in the nostril of the sort of unpigmented area of skin. He had this recurrent plaque which would sort of particularly flare up during the summer months and the sunny months in his right nostril. It was obviously uncomfortable for the stallion. Flies would come and visit it, as you would imagine, and feed there. There was a constant history of secondary infection there as well, and also the owners were worried that this is a tumour which does spread potentially to other organs, so we were all worried about that. Here we are here we are a couple of months after having done the surgery and done photodynamic therapy as an adjunct. Great result. Again, this case we would have treated probably 3 years ago. Again, still firmly in remission, no signs of the tumour coming back.
Sorry, just on that last one.
Yeah.
Obviously that's an Arab. Is there any research that's been done specifically around certain breeds that are more susceptible to sarcoids? Because, I mean, my mare's had 2 sarcoids, both of which have been treated very successfully. But I remember when she was diagnosed, I did some, human nature, you go on the internet, you look and everything. And I can't remember where I see it, but I read somewhere that Lipizzaners don't ever seem to get sarcoids.
That's very true, yes. Yes.
So is there any research that says certain horses, like Arabs, I mean, if you think about that breed, sunshine, very fly conditions, obviously in their normal terrain, do they get loads and loads of sarcoids when they're actually in their home lands?
There definitely aren't breed predilections that we recognise to all of these tumours, for instance. So we know that there was some work done. Most of the genetic work, actually, strangely enough, given the fact that we're now sort of in a very much a genetic age where everything seems to be about DNA, there aren't many genetic studies, unfortunately, being done currently. The last studies looking at genetic predisposition to sarcoids, for instance, were done back in the 1970s. But some of that work, for instance, by some workers called, principal worker called Lazary, and his colleagues looked at some French warm bloods and found that they were 14 times more likely than other warm bloods to develop sarcoids. So very clearly there is some kind of a genetic influence there. And we know that certain breeds are more prone to developing them. So thoroughbreds, for instance, quarter horses and so on, Appaloosas, do seem to be overrepresented. And similarly, other types of tumours we find much more commonly in some particular breeds. So as you say, with Lipizzanas, they don't develop sarcoids, but of course they do develop melanomas. So the University of Vienna Vet School, my friends and colleagues there spend a lot of time dealing with melanomas, but don't really have to do any sarcoid work with the Lipizzanas there. So yes, there are breed predilections, and in fact, my research group at the university and Red Wings again, this summer we are going to do some genetic work actually. We're going to look at the cases that we've treated for sarcoid. It's going to be a blinded study. We'll have students going out and taking DNA from the horses. They won't know which horses have been treated for sarcoids and which haven't. We'll collect DNA from them, from horses which haven't developed sarcoids, and then we'll do DNA analysis effectively to look at which genes are switched on and which genes are switched off in the two groups of horses, and try and see whether there are particular genes associated with the development and non-development of sarcoids. So that's quite an exciting project. I think we're looking forward to seeing the results of that. This is a case I saw last summer, quite an interesting case. So this is pretty typical for squamous cell carcinoma on an unpigmented area of skin. This is pretty strange. This is a 11-year-old black cob gelding, pretty hairy thing. I don't think there's an awful lot of sunshine getting through to the skin underneath there, and yet this rather bizarre lesion came up. The referring vet did take a biopsy of it, sent off, and it came back as being confirmed as squamous cell carcinoma. Yes, we decided the horse was insured. We were concerned about it metastasizing. It seemed to be quite an aggressive lesion. It had come up very quickly. So we decided to go for carbon dioxide laser excision. There we are. We did that standing just at the owner's yard actually, we sent it off for histopathology, off to the lab. And as you can kind of imagine, sitting there, it's quite difficult to get very deep underneath that with surgery, just because of the anatomy of the leg. So we decided to use acyclovir post-operatively as well, and also we decided to use photodynamic therapy with it as well. And again, that seems to have done extremely well. No signs of the tumour coming back, and just such an unusual case that I think it's one that we'll probably write up actually. So we've crunched some numbers for this. This is work that I presented at the British Equine Veterinary Association Congress this year. So we assessed a number of periorbital sarcoids that we treated with photodynamic therapy and laser. A mixture of lesions, so some verrucous type lesions like this, fibroblastic lesions and so on. Follow-up with these range from 6 months to 3 years. Majority of the patients were just treated standing, and some of them, as I say, out at the owner's yard actually. So this is in the wilds of Wales, we've managed to fashion a bizarre dressing. This is during that 3-hour period whilst the cream stays on the tumour before we put the light on, and we don't want any other light to get onto the area, so we've fashioned some bizarre vet wrap type dressing. And these were the results that we got. We had follow-up on, of the 21 cases, we got follow-up on 16 of them, and 15 of them were disease-free after at least 1 year. The one which wasn't was Sammy, the pony that we treated with Mitomycin. Remember the little grey pony from Red Wings. So the vast majority did disease-free. We had some short-term complications in 6 of our patients. We had a transient keratitis, so just an inflammation of the eye in one of the cases, and we had some swelling around the eye in rather more cases. But again, these were all things that we could treat very simply just with non-steroidal anti-inflammatories. This technique is a lot cheaper than sending horses off for radiotherapy, for having the wires, for instance, threaded through the tumours. It's probably a third to a half of the price of that, well, probably a third of the price of that. So very cost effective with a very similar remission rate. I don't think that you would get much better remission rates than that, even using radiotherapy. So, as I said, it's a well-validated technique in human medicine, and looks like it's a very useful technique for us to use, not just in horses actually. I gave this presentation at the Royal Veterinary College a few months ago, and the small animal vets were very interested in perhaps using this technique for small animals too. A couple of case examples. This was the first one that we did, again at Red Wings. They seem to be very supportive and keen, I think, to try new things that have good validation behind them from human medicine. So 6-year-old pony gelding, you can see it's got this unpleasant fibroblastic lesion over its eye, which was rapidly growing, making us worried about discomfort. Pony's cited, of course, fly worry, secondary infections, all the things that you'd expect. Also, it's quite a young pony, so they were hoping that they were going to rehome him. Here we are. This is 3 months after PDT and surgery. So a really nice result and a great cosmetic result. You can't see there's been any treatment done there at all. So we debulked the tumour. Didn't feel that we were going to get a margin around it. Treated it with PDT and then we go. This is another Red Wings case. And the reason I use this as an example is because this area here has been treated with radiotherapy. This had been treated with radiotherapy at Liverpool University some months before this then appeared. A new sarcoid appearing at the front aspect of the eye. There had been a large sarcoid here at the back of the eye which had been treated with radiotherapy. They were concerned again about Angus's well-being. It was obviously uncomfortable for him, worried of course about his sight again, and the same things really that we've looked at before. Here's Angus with his ridiculous dressing after the first of the treatments. Here we are between the first and the second photodynamic therapy treatment. So this is a week after we've taken the tumour away or debulked it with the laser. And it's already had one photodynamic therapy treatment on it already. Here we are just after the second treatment. It's interesting, very often after the first treatment we don't seem to get an awful lot of reaction. But after the second treatment we seem to get a lot more reaction. So here we are, this is just a week after the second of the treatments. So we've got a reaction, which is a good thing. Again with Mitomycin, you want to see that there's going to be reaction. Same with photodynamic therapy. Kind of suggests that something's going on, something beneficial is going to happen. Here we are, 3 weeks after that treatment, and here we are 6 weeks after the second treatment. And I guess perhaps it's a little naughty to kind of compare with the radiotherapy lesion, but you can see things have healed up much faster. No sign of the tumour there.
Did you touch the other one?
No, didn't do anything with the other one, just left that, yeah. I think Red Wings had spent a lot of money on this lesion, and when the new lesion appeared, Angus unfortunately run out of money in his piggy bank, and they thought, well, we can't really justify setting him up for another round of radiotherapy. So again, I think the comparison is kind of clear there. I know which way I would go, given the time it was. Okay, right, so, yeah, it's a relatively simple technique, some sort of specialist kit required to do it, very good efficacy rates that we're getting at the moment, pretty minor adverse effects that we've seen with the treatment as well, which have been very easy to treat, relatively low cost compared to the other treatment options for periorbital sarcoids, and most of the cases, as you saw, we can treat standing, just with good sedation. Okay, so you'll be pleased to hear that's the end of the talk. Just a few thank yous. First of all to Andy and all the team here, Alice for organising this evening, thank you very much for inviting me. To Peyton Lee in Essex, which is one of the practices who supported us with the follow-up surveys. Red Wings, mentioned them ad nauseam, but again they've been very supportive and they're great colleagues that I enjoy working with. And of course Nottingham Trent University as well, who supplied the students for data gathering as well. So thank you very much. Any other questions?
Sophie, you had your...
No, not really. I think can most veterinary practices offer this treatment, or do we have to travel our horses? Or?
No, basically my practice goes out to other people's practices. So practices.